I am Dr. Mahmoud Al-Sheikh Ali. Today we're going to speak about a chronic kidney disease, CKD. We're going to speak about the definition of CKD, the causes of CKD, risk factors, some definitions, and we're going to speak about manifestation of CKD, complications in details, and we're going to speak about management regarding investigations and treatment. And at the end, we're going to summarize the lecture. These are the objectives. So chronic kidney disease, CKD, includes a spectrum of different pathophysiological processes associated with abnormal kidney function. So this wide spectrum of different pathological processes all associated with one thing, which is abnormal kidney function and a progressive decline in the GFR, glomerular filtration rate. The definition of CKD have been changed over the last decades, and now it's defined as presence of structural or functional evidence of kidney damage for more than 3 months duration, or GFR less than 60 milliliter per minute, 1073 meter square, more than 3 months duration. Again, CKD defined as the presence of structural or functional evidence of CKD. So what are the structural or functional evidence? That means impaired kidney function test or abnormal urine analysis or structural abnormalities on imaging or on biopsy. If these changes continues more than 3 months, it will be CKD. Or if the GFR continue to be less than 60 for more than 3 months, it's again CKD. National Kidney Foundation classification of CKD come with the stages of CKD. There are 5 stages of CKD. Sorry, 6 stages of CKD, from 0 to 5. All these stages are identified by GFR, glomerular filtration rate. So it's stage 0, in which I think everybody is in this stage. Is defined, GFR is normal, more than 90, with risk factors of CKD. We're going to speak about risk factors later. Second, stage 1, when the GFR is more than 90, with kidney damage, with normal or high GFR. We call this stage hyperfiltration stage, and we're gonna explain why this stage called hyperfiltration and why hyperfiltration happens. Stage 2, kidney damage with mild decrease in the GFR. So at stage 2, we start to see decrease in the GFR, but it stays more than 60. So it is 60 to 89. It is less than 90. Stage 3, this is very important stage in which GFR is decreased further from 59 to 30. And because this stage is very vital regarding management and diagnosis, we have divided it to 2 stages, stage 3A and stage 3B. Stage 3A when the GFR is 59 to 45, and when GFR 44 to 30, we call it stage 3B. Stage 4, severe decrease in the GFR to less than 30, 29 to 15. And the stage 5, when the GFR is less than 15, or patient on dialysis, that means established renal failure. These are the stages. So we're going to speak about few definitions. The old term chronic renal failure, which have been replaced by a wider term CKD. As you see, CKD includes stages with normal kidney function test, with hyperfiltration, and with mild, moderate, or severe decrease in the kidney function. So it have been replaced, the chronic renal failure term have been replaced by CKD, but it's still in use. So when we say chronic renal failure, this applies to the processes of continuing significant reversible reduction in the number of nephrons, and it typically corresponds to stage 3 to 5. The term end-stage renal disease represent a stage of CKD where there is accumulation of toxins, fluid disturbances, and electrolyte abnormalities, and this stage characterized by uremic syndrome. We're going to speak about why these stages have been identified. But let's first speak about pathophysiology of chronic kidney disease. It's very complicated, and because CKD includes wide spectrum of different pathological processes, the pathology of this condition is very complex. But to understand it, we have divided CKD pathology to two broad sets of mechanisms. First, initiating mechanism, and second, progressive mechanism. Initiating mechanisms. These mechanisms are specific to underlying etiology, like diabetes, hypertension, immune complexes, mediators of inflammatory of certain types, like nephritis, or toxin exposure. So this is initiating process, which leads to nephron damage or glomerular damage by different causes. Once this damage happens, the kidney tries to compensate, and in this, a set of progressive mechanisms start. These mechanisms involve hyperfiltration and hypertrophy of the viable nephrons that are common consequence following long-term reduction of renal mass, irrespective of underlying etiology. So first set of mechanism is dependent on etiology. The second, progressive mechanisms, is not dependent on underlying etiology. It's a self-progressive process. Why this happens? When initial insult happens and the kidney loses some nephrons, the surviving nephrons tries to overtake the function of lost nephrons. And this is mediated by mainly two factors. First, cytokines like interleukins, growth factors, etc., and by activation of RAS system. These growth factors and cytokines leads to hypertrophy of the surviving nephrons, and once hypertrophied, its function is also increase, and thus we have seen a stage of hyperfiltration, which was the first stage. The rice system again plays vital role in this process because hypertrophied nephrons lead to hyperfiltration by activation of rice system. As you know, rice system leads to constriction of the efferent arterioles, and this leads to increase of the intraglomerular pressure, which is the main defining factor for filtration. Once the intraglomerular pressure increase, the filtration is also increased. But this process, unfortunately, have backdraws. These surviving hypertrophied and hyperfiltrating nephrons cannot stand this rise in intraglomerular pressure, and eventually they lost. And other surviving nephrons overtake their function by the same mechanism, and they face the same fate. At the end, the number of nephrons decreases, and we start see the progression of CKD from stage of hyperfiltration to a decline in the GFR, mild, moderate to severe. And this process is not dependent on the underlying cause. So this is the pathology. So back to our subject, which I have spoken about, which is why these stages are important. These stages are important because, as you see, this process is a progressive, and once started, it can lead to loss of nephrons, and more it continues, we lose more nephrons. So if we catch it up at early stages and we try to manage, for instance, at stage 0, 1, and 2, if we try to correct the risk factors and causes, we are going to delay the progression. And if we catch it at stage 3 and we start management to reduce the progression, we can delay at least the progression by few years. For patients to whom it can take 1 to 2 years or 3 years to pass from stage 3, for instance, to stage 4, if we manage them at early stages, this time we can at least double it. And this is very good for patients because one day without dialysis or without renal replacement therapy deserves this effort. So it is very vital to manage this patient at the early stages. Acute kidney injury, we have spoken about this subject, which is different pathological process from CKD. Proteinuria and hematuria, we're going to speak about these in the lecture of glomerular diseases, etiology and epidemiology. We don't have statistical data, but in United States, 6% of adult population are at stage 1 and 2, and an additional 4% at stage 3 and 4. So collectively, we have 12% of United States population at any stage of CKD. So it is widespread disease. The most frequent causes. Causes more than 50% of the causes are diabetes, and mainly type 2 diabetes. Although type 1 is mainly have microangiopathic complication, and it leads to nephropathy and retinopathy more than type 1, but statistically type 2 consists about 85% of all cases of diabetes. Ultimately, this leads to DM type 2 to become the most frequent cause of CKD. As I have mentioned, it consists about 45 to 50%. The second cause is hypertension. So it consists about quarter of cases, 20 to 25%. So collectively, DM and hypertension are responsible for 70%, two-thirds of patients of CKD. This is a huge number. Other diseases, which is also important, glomerulonephritis, which consists about 10% of CKD to 11%, pyelonephritis 4 to 5%, polycystic kidney disease and renovascular disease 1%. These are the most common causes of CKD. On the top of the list, DM and hypertension. Which population is at risk? It's important to identify factors that increase the risk for CKD even in individuals with normal GFR. And we have spoken about this because it's vital to pick them early and manage them early to delay the progression of CKD from stages 1 to 2, etc. So what are the risk factors? Patients with hypertension are at highest risk. Although hypertension is the second commonest cause, but in the progression of CKD, controlling blood pressure is more important than controlling of the underlying cause like diabetes. Patients with diabetes, especially uncontrolled diabetes, are at risk to develop CKD. Patients with autoimmune disease, older age, senile kidney are also at increased risk. African origin, family history of renal disease, previous episodes of AKI, or the presence of abnormal urine sediment like proteinuria, hematuria, or abnormalities of the urinary tract. Those patients are at increased risk to develop CKD. The common question in practice anybody will face whether this AKI or CKD. So to answer this question, whether this, if you have a patient which you have seen only now and his creatinine is supposed to be 5 and you calculate the GFR, it's low, how you can know this patient is having acute kidney injury or CKD? To answer this question, you need to take good history and physical examination. They can give you the answer. And to confirm this, we need ultrasonography. Shrinking kidney is usually due to CKD, except in few conditions. For instance, if you have a patient with long-standing diabetes or diabetic retinopathy and microangiopathic and microvascular complications, and in routine analysis, you find his creatinine supposed to be 4 or 5. The history says that this is CKD. Or if you have a patient in a surgical ward who have major surgery with bleeding, or a patient with severe vomiting or diarrhea, the clinical scenario suggests that this is acute kidney injury. Why early detection is important? We have spoken about this. So what are the factors leading to progression of CKD? Once the patient has CKD stage, at any stage, why he passes from one stage to the next stage? The main is poor control of blood pressure. So this is one of the key points which you have to address in your management. Second, poor diabetic control. And we know that A1C level is linked to deterioration of the kidney function test. Hyperlipidemia also the cause. Smoking is a cause. High phosphate diet and high protein diet. Not because high protein and high phosphate leads to increase of toxic products, production of toxins, but it is for unknown reason. High protein diet increases the production of growth factors and cytokines, and we have mentioned their important role in the process, in the second type of pathological mechanisms. The last cause of deterioration of the CKD is anemia. So those patients shouldn't be anemic, and you need to address all these points: blood pressure control, blood sugar control, hyperlipidemia control, smoking cessation, dietary modification, and keeping normal hemoglobin according to the guidelines is very vital in management of CKD. That's good. So far, we have mentioned the definition, causes, risk factors, causes of progression, differentiation between acute and chronic, and pathology. Now we're gonna move to evaluation and management of patients with CKD. We should first admit that this is one of the most difficult scenarios in medicine to manage and to evaluate a patient with CKD. But we need to organize our approach. First, as any case in medicine, we need a good history and a good physical examination. Secondly, we need to do some laboratory investigation, and thirdly, imaging studies. And again, history and physical examination should focus not only on manifestation of CKD, but also on complication of CKD, possible causes of CKD. So you have to cover all these during your history taking and physical examination. This also applies for laboratory investigations. We need some investigation to diagnose CKD, to look for the cause behind it, and to see the complication of CKD. And imaging studies also the same. History. The commonest manifestation of CKD is silence. So those patients usually come to see a doctor for routine visit or for something else. What if the kidney, the CKD, have manifestation? It usually non-specific, and the top of the list is GIT symptoms and constitutional symptoms like fatigue, etc. So in the history taking, we need to take his detailed history about hypertension, diabetes, and abnormalities in the pregnancy, and abnormalities in urinalysis, drug history, and especially for nephrotoxic substances. We need to ask about uremic syndrome, like asking about appetite, weight loss, GIT manifestation like nausea, vomiting, hiccups, peripheral edema, muscle cramps, pruritus, restless leg. The manifestation of CKD usually at stage 0, 1, 2, we have the manifestation of the underlying cause rather than the manifestation of CKD. At stage 3, which we have divided it to 2 stages because it is very important, we can find only some metabolic disturbances like hypocalcemia, anemia, hypophosphatemia, some endocrine abnormalities. We're gonna see uremic manifestation at stage 4 and 5, which is too late. On physical examination, we have to focus on, again, blood pressure measurement is very vital and follow with evidence of target organ damage from hypertension. Pericardial examination for left ventricular heave, fourth heart sound, pericardial friction rub, which is a medical emergency, and renal bruit. Fundoscopy is important in a diabetic patient seeking evidence of diabetic retinopathy, which is associated with nephropathy or hypertensive changes. This is very important point because it can solve for you a very complicated issue. So whether the patient having CKD due to diabetes or other cause, and you are not aware whether this diabetes which led to CKD, or patient have, for instance, Glammer disease. The answer you can find in the back of the eye, in the retina. If the patient has retinopathy, most likely the diabetes is the cause of his nephropathy. Although in some atypical cases, patient could have nephropathic changes, diabetic nephropathic changes without retinopathy. 90 about 85 to 90% of patients with diabetic nephropathy would have any stage of retinopathy. The reverse is not true. So not patients with retinopathy doesn't have nephropathy by this percentage. They usually have nephropathy of about 5 to 10% of cases. You look for other signs like pallor, jaundice, edema in lower limbs, rise in GVB, or in the pericardial effusion, pleural effusion, or ascites. And you look for CNS manifestation, mainly astraxis. Laboratory investigation. Search for clues to underlying cause or aggravating factors which lead to damage. So we need to test for blood sugar. We need to test for SLE, vasculitis, serum electrophoresis, and protein electrophoresis if the cause is unexplained and we suspect myeloma kidney, especially if the patient have anemia, hypercalcemia, or even inappropriately normal calcium. As you know, calcium should be low in CKD, or if it is appropriately normal, you should suspect multiple myeloma. Infectious etiologies such as hepatitis B and C and HIV and cryoglobulinemia. In some instances, you have to look for malignancy because malignancy can lead to nephropathic changes or glomerular disease. Serum measurement of renal function should be obtained to determine the base of renal deterioration. So you have to see at which stage patient is and whether he is deteriorating or stabilized, and ensure that the disease is truly chronic rather than subacute and hence potentially reversible. As we have mentioned in the lecture about KI, it is a potentially reversible condition. But in CKD, especially at stage 3 downward, is irreversible. You need also to see serum calcium and phosphorus and parathyroid hormone level for metabolic bone disease. Hemoglobin concentration is also important, and you need to know the level of iron, B12, and folate as hematinics. This has impact not only in diagnosis but also in management if the patient is anemic. A 24-hour urine collection may be helpful in some instances, especially glomerular disease. How to calculate GFR? The golden standard is isotope scan, but this is done only for research methods. And the main assessment of the GFR is done by eGFR, estimated GFR, which is calculated by Fermat. And in your mobiles, you can have an application which calculates it for you, so you can download it. We also assess kidney function by 24-hour collection, which is sometimes is not accepted by patients and sometimes difficult for patients and doctors and not sensitive. And we have replaced it by something called ACR, albumin creatinine ratio, or albumin protein ratio, or protein creatinine ratio. KGFR is calculated by Korsakoff-Gault formula equation, which is 140 minus age per years multiplied by weight in kg, and this divided on 72 multiplied by plasma creatinine. And if your patient is female, you multiply all of this to 0.85. And this is widely accepted. Imaging studies. The most useful imaging study is renal ultrasound. It can be helpful in variable ways. It can determine if the kidney is symmetrical or asymmetrical. A symmetrical kidney denotes renovascular disease, especially if the size difference between two kidneys is more than 1.5 cm. It also provides an estimate of the kidney size, rule out renal masses, and obstruction. Since it takes time for kidney to shrink as a result of CKD, the finding of bilateral small kidneys support the diagnosis of CKD of long-standing duration, which is reversible and denotes scarring of the kidney. If the kidney size is normal, it is possible that the renal disease is acute or subacute or at early stages of CKD. But for this, as for any rule, there is exception. There are few exceptions. The exceptions where you can find CKD with normal or large kidneys, diabetes, early stages, diabetic nephropathy, where you can find hyperfiltration, amyloidosis, HIV nephropathy, polycystic kidney disease, multiple myeloma with amyloidosis, obstructive nephropathy. So it is um, the renal size is usually small, apart from these five conditions. Discrepancy of more than 1 or 1.5 cm between the size of two kidneys suggest renovascular disease. In such cases, you need to do angiography, whether the CT angio or MRI angio. But make sure that you don't use contrast medium to prevent a famous and common complication, which is SEN, contrast-induced nephropathy. Finally, in case of CKD, we may need to take renal biopsy, and this is usually taken ultrasound guided, which is a favored approach, and in some instances it is done transjugular to limit the complication. Kidney biopsy is frequently needed to determine the diagnosis, indicate what is the cause, predict the natural history, and the prognosis of the injury, and in some instances it is vital to direct treatment. But when less invasive diagnostic studies cannot determine the cause of the condition, and the clinical signs and symptoms suggest that the pathological evaluation may be diagnostic. For example, in patient with concomitant hematuria and proteinuria, which suggests renal disease, we may need to take renal biopsy. such as an adult with nephrotic syndrome or glomerulonephritis with no obvious cause, in children with steroid-resistant nephrotic syndrome, in all patients with acute kidney injury with unclear cause. And renal biopsy is mandatory to give us vital information about severity and potential reversibility of the renal damage and what is the best treatment. But again, bear in mind the important contraindication to do renal biopsy, which is solitary kidney. Patient with one kidney, you wouldn't risk this kidney. Patient, if uncooperative, you cannot do renal biopsy. Or patient with hemorrhagic tendencies and controlled severe hypertension is also contraindication, especially if it is more than 180 over 110. Presence of hydronephrosis or active UTI is again contraindication. Presence of multiple renal artery aneurysms, this risks bleeding and also contraindication. Multiple masses with the kidney in case of renal cell carcinoma. Taking biopsy may lead to spreading of the tumor. And not only this mass is the contraindication, but presence of cyst, abscess, or kidney neoplasm sometimes is a contraindication. Bleeding diathesis and morbid obesity because you cannot do compression over the kidney. These are contraindications to do renal biopsy. So the CKD we still need to speak about complications and management in details. But in this part of the lecture, we're gonna end here and I'm gonna summarize the lecture now. So I've spoken about CKD, which includes wide spectrum different conditions and defined as the presence of structural or functional evidence of kidney damage for more than 3 months, or GFR is less than 60 for more than 3 months. We have spoken about 6 stages of CKD: stage 0, 1, 2, 3, 4, 5, all dependent on GFR. Stage 0 means the presence of risk factors, but the GFR is normal. Stage 1 hyperfiltration stage means GFR is increased. At stage 2 it starts to decrease to less than 60 to less than 90, from 89 to 60. Moderate decrease 30 to 59, which is stage 3, which we have divided it to A and B, and stage 4 and 5 is GFR decrease to less than 30 and 15 respectively. And we have spoken about chronic renal failure, which is term applied for stages 3 to 5, and end-stage renal disease when we have uremic symptoms. The pathology of CKD includes 2 sets of mechanisms: initiating mechanism, which is dependent on the underlying cause, and progressive mechanisms, which are not dependent on the underlying cause and mainly dependent on the activation of RAS system and activation of cytokines and growth factors. And etiology of the CKD, the commonest is diabetes and hypertension. Both consist about 70% of the cases. Other causes like glomerular diseases which is very wide causes of glomerular diseases, pyelonephritis, polycystic kidney disease, and renal vascular disease. And they are spoken about which factors may lead to progression of CKD, and on the top of the list is uncontrolled hypertension, uncontrolled diabetes, hyperlipidemia, smoking, high protein diet, and anemia. Evaluation and management of patients with CKD includes history and physical examination, laboratory investigation, and imaging studies, all directed towards looking for the condition, which is diagnosing the CKD, looking for its possible cause, and looking for the possible complications. And we're going to focus on symptoms, which involves almost all systems from CNS, GIT, respiratory, cardiovascular, neurological, endocrinology, and skin, and etc. On physical examination, again, we have to focus on findings that suggest CKD, generally, or more in local examination, general like pallor, blood pressure, jaundice, etc. And we have to examine cardiovascular system, abdomen, certainly, and chest, and CNS examination. Fundoscopy is vital to answer some questions. Laboratory investigation, which include looking for the cause like blood sugar, SLE screening, vasculitis screening, or paraproteinemia screening, or cryoglobulinemia and malignancy. And it's also, we need investigations to look for possible complication regarding calcium phosphate and blood and hormones, and also we need urine analysis and sometimes urine collection. The main the calculation of estimated GFR is very vital, and you have to memorize this equation, which is 140 minus age per years multiplied by body weight in kg divided on 72 multiplied by plasma creatinine. And if your patient is female, you multiply all of this to 0.85. And imaging studies, on the top of the list, ultrasonography, or we can also use some angiography, MRI, or CT angiography to diagnose renal vascular disease. Renal biopsy is taken in conditions where you need to determine the cause or direct treatment or have some insight about prognosis. But it again have enormous contraindication, which you should bear in mind. Thank you.